Morning guys, I'm Zeus. I'm a CRNA at a community hospital, and today I'll be on call for 24 hours. So the first case of the day is an ankle ORAF, that's open reduction, internal fixation. Basically, they'll fix this broken ankle with plates and screws. My anesthetic plan for this is general anesthesia, and I'll do a popliteal sciatic nerve block and an adductor canal nerve block for post-operative pain control. Before the patient even enters the room, I make sure everything is prepped and ready. For ortho cases, I always confirm the tourniquet is in the room and the correct cuff size is available. On my end, I've got suction tested, airway gear is set up, and I draw up full induction and emergency meds. Also, monitors are ready. I like to walk into every case knowing I'm ready for anything. Once the patient rolls in, it's go time. In this case, I'm performing a popliteal sciatic nerve block. This block provides anesthesia and post-op analgesia to the foot, ankle, and lower leg. When combined with a saphenous nerve block, it covers the lower extremity below the knee. I start by placing the ultrasound probe in the popliteal fossa to locate the popliteal vessels with the tibial nerve slightly lateral. Scanning proximally, I find where the common peroneal and tibial nerves join to form the sciatic nerve. I prefer to block as they converge, advancing the needle in plane and injecting 20 to 30 mLs of local anesthetic. This provides dense anesthesia and excellent post-op pain control. For this case, I used ketamine. It's a strong analgesic with dissociative effects while preserving airway reflexes. All done with the first case, taking a little breakfast break before we get to the next one. It's going to be an IND and wound vac placement for a lower extremity wound. For this incision and drainage and wound vac placement, I'm setting up for general anesthesia. I've got full airway setup ready, ET tubes, LMAs, suction, and backup gear. Induction meds are drawn, propofol, fentanyl, and rocuronium. The next case coming up is a laparoscopic appendectomy for a pediatric patient. Now, doing anesthesia for any patient requires 100% of my attention, but taking care of pediatric patients always requires an extra degree of focus. For any pediatric case, I keep the pediatric cart in the OR. It's stocked with airway gear, IV supplies, and equipment sized for smaller patients. All pediatric medications must be dosed strictly by weight. Accuracy is everything when it comes to kids. Pediatric airways are different. Their heads are bigger compared to their bodies, their tongues take up more space, and their voice box sits higher and more forward. Here I am drawing up medications. I wasn't able to capture everything on camera due to the unpredictable and fast-paced nature of the day. Additional cases were added, including 2 more lower extremity incision and drainages, a laparoscopic cholecystectomy, and emergency intubation in the emergency room. Days like this highlight the importance of staying prepared and adaptable in anesthesia practice. All right, guys, all done with cases in the OR for now. I'm off taking a walk with the baby, getting some fresh air. I've got to stay close by. They could always call for another emergency or a labor epidural, and I'd have to go run back in. Thank you so much for watching. I hope you guys enjoyed this day in the life of a CRNA on call. If you're interested in seeing more content like this, please leave a comment below. Also, don't forget to like and subscribe. See you guys in the next one.